Welcome very much to today's presentation. Just kind of a heads up for you as far as what I will be sharing with you this evening. Basically, we're going to be talking about state and federal statutes that pertain to appropriate prescribing. If you are not all aware, the Michigan Public Health Code and the Board of Pharmacy Administrative Rules requires that every pharmacist licensed in the state be knowledgeable of state and federal statutes. And we're going to talk about several key areas which tend to raise a lot of questions or may cause some issues in the pharmacy, and hopefully by the end of the presentation today you'll have a greater understanding of those areas. First, I'd like to talk about some valid signature requirements on prescriptions and start with probably a basic, but again some area that causes some question on who may actually sign a prescription. And the answer, the prescriber. And if you're interested in where the statutes are in the Public Health Code and the CFR, which is the Code of Federal Regulations, which just describes that, they're found here. Now, it may seem simple about what the prescriber is. There's still lots of questions. And so I'll have a slide later on that'll be more specific with regards to who a prescriber actually is. A couple other areas that raise some question is the definition of a signature. And if you look at the Michigan Public Health Code as well as the Code of Regulations here, you'll see that it clearly defines what a signature is. And while I'm not going to read this entirely, a key element that you must be aware of is that when it talks about signing a prescription, it means you sign in the same manner in which you would a check or a legal document. So for example, Karen Jonas would sign a check with Karen Jonas. There's nowhere is it authorized for Elizabeth Dedato to sign Karen Jonas's name to a check. So sign is signing your own signature. So when you think about definition of signature as we move forward, keep that in mind. So let's go back and talk about who qualifies as a prescriber. So that is a licensed dentist, a doctor of medicine or an MD, a doctor of osteopathy or surgery, or a DO, a licensed optometrist, which is certified under certain Part 174 in the Public Health Code, a licensed veterinarian, individuals that are acting under delegation of an MD or DO, such as the mid-level prescribers, the physician's assistants, the nurse practitioners, or the certified nurse midwives, or CNMs, as you see down there. So thinking back now to what we talked about on who a prescriber was, and also what the definition of sign was, can somebody else sign a prescription for a prescriber? And the answer is no. And here again are the statutes that clearly reflect that an individual cannot sign another person's name. So you see in your pharmacy a prescription that's been prepared by a nurse, and it's countersigned Karen/Dr. Dedato. That's not a valid signature. Somebody else cannot sign on behalf of a prescriber. An agent can prepare a prescription, but they cannot sign on behalf of a prescriber. So you need to be very clear of that. That's a common area that pharmacies get tripped up on, particularly in audits, as they'll see a lot of prescriptions that will be signed by somebody other than the prescriber. So just additional clarification. A prescription can be prepared by the secretary or agent, in other words, other individuals in a physician's office, but they can prepare it only insofar as they get down to the signature, and then at that point the prescriber themselves must sign. And they've got to sign in the same manner in which they would sign a check or a legal document. Now, here's the area that confuses a lot of the staff in the office. They can pick up a phone, I'm the physician's secretary, or I'm on office staff. If the physician so authorizes me and I'm sitting in their office clinic, if I'm authorized, I can pick up the phone and call the pharmacy and verbally communicate a prescription to that pharmacy, but they cannot sign the entire prescription away. It confuses a lot of the office staff. It confuses some of the pharmacies. So be very clear when you're accepting prescriptions that they need to be signed by the prescriber and not by somebody's name/counterpart and then the prescriber. So let's delve a little bit further into signature requirements and look at what type is valid for a prescription. If we look at scenario number 1 here, a patient presents to a pharmacy with a handwritten prescription. The prescription must contain a manual or wet signature for any drug, whether it's controlled or non-controlled. If the patient presents to the pharmacy with a handwritten signature that contains a stamp, it's not valid. It's got to be a handwritten or wet signature. Okay, scenario number 2. An electronically prepared prescription is printed out in the physician's office, and then the patient delivers it to the pharmacy. So it could be computer generated. It could be an 8x10 physician's order sheet containing multiple orders. It could be a single electronic prescription, but it's presented to the pharmacy. What type of signature is required? You can see here the answer is very similar as it is for a written prescription. The prescription must contain a manual or wet signature for any drug, controlled or a Schedule 3 through 5. And actually for 2 also. So I apologize, everybody. There's an error on my slide already. I noticed it 2 through 5. So electronically prepared, it's printed out, handed to the patient delivers it to the pharmacy. It must contain a manual signature. So if you see a prescription in the pharmacy that's electronically prepared, it's hand-delivered to you, and in the bottom it says electronically signed, it's not valid. It must have a manual signature. Okay, let's look at situation number 3. You in the pharmacy receive a handwritten prescription, or you get one that's handwritten in the physician's office, but that's faxed to you to your pharmacy fax machine. What type of signature is valid? Same type of scenario. It's still considered a manual prescription, so it must contain a wet signature. The definition in the Michigan Public Health Code for electronic prescription is computer to computer or physician's computer to the pharmacy's fax. If it's coming from physician's fax to the pharmacy's fax, it's not valid with an electronically signed signature. It must contain a manual signature. Scenario number 4 here. A physician's office communicates an electronic prescription from their computer directly to the pharmacy's fax. I just kind of gave you the answer there a minute ago. Again, the Michigan Public Health Code recognizes electronic prescription coming from the physician's computer to the pharmacy's fax or the physician's computer to the pharmacy computer. So in this situation, if you receive a prescription to your fax machine and you know it's coming from a physician's computer, an electronic signature would be valid for a non-controlled substance, and an electronic signature would be valid for a controlled substance once both your pharmacy's software has been DEA certified and the physician's software has been DEA certified. If one of the 2 of those certifications has not yet been completed, then your pharmacy cannot accept an electronic signature on a controlled substance. Hopefully that's clear, and if I need to clarify later, I'd be happy to do so. Okay, let's look at the 5th situation here. A prescription is communicated directly from the physician's computer to the pharmacy's computer. And again, we talked about the definition in the Michigan Public Health Code. Electronic prescriptions valid from the physician's computer to the pharmacy computer. So in this case scenario, an electronic signature is valid for a non-controlled drug, and it would be valid again for a controlled drug once your system has been DEA certified and the prescriber's software has been DEA certified. Now, one point I'd like to make clear for you is there are several companies out there that already have their pharmacy software certified by the DEA certification vendors. And we are aware of many physician software companies that have gone through the certification process. You are authorized, according to the DEA rules, to ask a physician for the DEA certification from their vendor to ensure you know that their software has been certified. Obviously, once you get to know these prescribers' softwares better, you'll know that, you know, Dr. Smith or Dr. Jones has already gone through the certification process. But in that meantime, if you are not aware that their software has gone through, and if your software has been certified, you have to be careful that you're not accepting an electronic signature on a controlled substance prescription that's electronically communicated to you if it's coming from a physician that has not yet had their software certified. So make sure you're aware that you have the ability to ask for that, a copy of the certification, or at least know where they've gone through the process. So again, I'm just going to reiterate what an electronic prescription is. And again, it's an original prescription communicated by electronic means from a physician's computer to the pharmacy computer, the physician's computer to the pharmacy facsimile machine, and again, to accept controlled substances with electronic signatures, both your software and the physician's software must be DEA approved through a certified DEA vendor. And if you're interested in a good set of FAQs that talk about that, the link is down here at the bottom. I know Elizabeth sent a copy of the slides out early. If you didn't get it, I'd be more than happy to provide this link to you after, because it has a great FAQ that you can refer back to with regard to this issue. And just for your benefit, this is the page on the DEA website that lists the DEA-approved certification vendors. There are actually 4 that have been approved, even though 3 are only showing up on this screen. I couldn't get the 4th one to show in when I copied and pasted, so just be aware that there are 4 vendors that are out there that have been approved by the DEA to certify e-prescribing platforms for controlled substances. Now I'd like to jump into mid-level prescriber prescriptions. This is an area that creates a lot of questions and confusion for the pharmacists as well as the mid-level prescribers, so hopefully when we're done you'll have a greater understanding of what's required on those prescriptions. And the first seems like a pretty straightforward answer, but it still messes a lot of practitioners up, and I'm not talking about just pharmacists, I'm more talking about the mid-level prescribers, and that is, are they independent practitioners? Unfortunately, a lot of them think they are, but they are not independent practitioners. They receive their ability to prescribe prescriptions or drugs, both controlled and non-controlled, under delegated authority by either a doctor of medicine, a MD, or a doctor of osteopathy and surgery, a DO. So they do get that under delegation. The delegation is supposed to be documented in the prescriber's offices. You don't need a copy of that delegation. However, one thing you need to be aware of is some of the nurse practitioners, physician's assistants, and the certified nurse midwives seem to think that I'm an independent practitioner, I can sign and write prescriptions only with my name, and that is not the case scenario. What you need to be aware of is that the name of the delegating prescriber must be noted on every prescription that that mid-level prescriber authorizes. So let's talk specifically about non-controlled substance prescriptions generated by a mid-level prescriber. And again, I'm talking about physician's assistants, nurse practitioners, and certified nurse midwives. Required elements of a non-controlled prescription obviously must be on there: the drug, the directions, the quantity, the patient's name. But when you get down to the logistics, it must be the signature of the mid-level practitioner that is listed on the prescription. So if I'm the mid-level practitioner, Karen Jonas must sign the prescription, and then the name of the delegating prescriber needs to show somewhere up on the prescription. So if I receive my delegation from John Doe, who's an MD, somewhere on my prescription it must show that John Doe, MD, is my delegating prescriber. Note, the delegating prescriber does not need to co-sign the prescription. That seems to still generate a lot of questions, thinking that both the physician's assistant or the nurse practitioner plus the MD or the DO need to sign the prescriptions. That's not the case. So just the signature of the mid-level practitioner, but the name of the delegating prescriber must show up on the prescription. Now let's talk about mid-level prescriptions for controlled substances. Again, the normal required elements of a controlled substance prescription, and again, I provided that statute for you, so obviously you've got name of the patient, name of the drug, strength, quantity, both written and numeric, directions, and again, the signature of the mid-level practitioner, the DEA of the mid-level practitioner, and they must have their own DEA number, plus the DEA number of the delegating prescriber and the name of the delegating prescriber. And again, just a reminder, mid-level practitioners are not independent prescribers. They are not authorized to use a DEA number of the MD or the DO. They must have their own DEA number to be able to prescribe controlled substances. So they must have their own DEA number, and both their number and the physician's DEA number must appear on that prescription, and obviously the name of the delegating prescriber and the signature of the physician's assistant, the nurse practitioner, or the certified nurse midwife. And again, same thing like with non-controlled prescriptions. The delegating prescriber does not need to co-sign that controlled substance prescription. So it doesn't need to be signed by Karen Jonas, who is the nurse practitioner / John Doe, MD. So just the signature of the mid-level prescriber. Hopefully that's clear. And again, if I need to in Q&A, I can address that with more clarity if I didn't make that clear here. Okay, now let's roll into exactly what a mid-level prescriber can write for. And I want you all to pay very close attention to the next couple of slides, because while we talked about what is a required element on the prescription for controlled substances for both physician's assistants, nurse practitioners, and nurse midwives, there is a distinct difference between which controlled substances those mid-level prescribers, and I'm talking the schedules now here, 2s through 5s, a physician's assistant can prescribe versus a nurse practitioner and a certified nurse midwife. So we're going to spend a little time now talking about just the physician's assistants. So I'm a physician assistant and I want to write for a controlled substance prescription for my patient. I am allowed, again, under delegation, the ability to write for a Schedule 2 through 5, any controlled substance within Schedules 2 through 5 without limitations of quantity or location of prescribing. So this applies to physician's assistants that are licensed in Michigan, acting under delegation to either a Michigan MD or a DO, and again, they must have their own DEA number. This does not apply to a physician's assistant practicing in Tennessee or Wisconsin or Illinois, because each state has different delegated authority, and therefore you must follow Michigan statute with regards to this. So for physician's assistants in Michigan, they can write Schedules 2 through 5 without limitation. Now this changed in the last year and a half. There used to be a restriction for physician's assistants only being able to write Schedule 2s for a 7-day supply from discharge from a hospital, surgical center, or nursing facility. That has been eliminated. So now any Schedule 2 through 5, no restrictions of where the patient resides, and no restriction of quantity. Okay, now let's move on to the nurse practitioners and the certified nurse midwives. And again, I'm going to caution you. Remember, there is a difference in Michigan statute right now between these types of mid-level prescribers. So, specifically with regards to the nurse practitioners and the certified nurse midwives, they can prescribe any controlled substance scheduled 3s through 5, and again, that's 3s through 5 without limitations of quantity or location of prescribing. For NPs and CNMs, they do have a restriction on Schedule II drugs. They can only write for a Schedule II drug for no more than a 7-day supply for a patient that's being discharged from a hospital, a surgical facility, or a hospice. So that is distinctly different than a physician's assistant, okay? And if the patient happens to be somebody that's going to a pain clinic within a hospital, that does not apply. It's for a patient that has been admitted and is being discharged. Somebody coming into the hospital as an outpatient service does not qualify. So be very clear on that part. And again, like the physician's assistants, this only applies to nurse practitioners and certified nurse midwives that are licensed in Michigan, acting under delegation under a Michigan licensed MD or DO, and the NP and the CNM must have their own DEA number. Again, they cannot use anybody else's DEA number, and be very clear that they do have a restriction on the Schedule II drugs. Now, the reason why I'm emphasizing that is because the bill at the end of the 2010 year that went into effect in 2011 that allowed physician's assistants to change, and then a clarification bill in 2012, did originally have nurse practitioners in that bill that would have removed the restrictions for them. And at their request, they removed themselves from a bill to work on a separate piece of legislation. So there was a lot of confusion even from the nurse practitioners who think they can write Schedule IIs now without restrictions, and that is not true. They have a restriction on Schedule II drugs, so be very clear about that. Okay, let's talk a little bit more about some controlled substance prescriptions and some other key areas that tend to raise some questions into the office, and pharmacists still have some questions on. A common one we get are more than one Schedule II drug allowed on a single prescription form, and the answer is yes. There was a law that was passed in 2010 that did allow more than one Schedule II drug to be on a single prescription form. It's the same law that extended the validity of a Schedule II prescription from 60 days to 90 days. So now we mirror federal law in that a Schedule II prescription, when it's written, is valid up to 90 days after the date it's issued, and you are allowed now to accept a prescription, a valid prescription that has more than one Schedule II drug on a prescription order. So be very clear about that, that is now authorized. Okay, let's talk a little bit about some out-of-state prescriptions. That also tends to raise a lot of questions. And when you're talking about non-controlled substances, the issue is much clearer than when you're talking about controlled substances. Because for non-controlled substances, you can basically accept prescriptions from any prescriber, and that would include a mid-level prescriber. So if a physician's assistant or a nurse practitioner wrote for a prescription for a hypertensive med, you could accept that. However, if you're talking about controlled substances, this is where there's their difference. You can accept as a pharmacist in Michigan a controlled substance prescription written for any schedule 2 through 5 from an MD, a DO, or a dentist from any state in the country, and including Washington, D.C. But you cannot accept a controlled substance prescription written by a mid-level prescriber in those out-of-state areas. So be very clear that, you know, non-controlled, not an issue. Controlled, there are an issue, and it must just be for an MD, DO, and a dentist. Now, this changed many years ago. It used to be only from surrounding states, the 7 surrounding states, but That also changed prior to 2009, and so that you can accept any schedule from an MD, DO, or a dentist regardless of what state they are licensed to practice in. I'd also like to talk a little bit now about what elements can be changed on a controlled substance prescription, because prior to a bill that was enacted at the end of 2011 and the start of 2012, by the time the governor signed it, the DEA referred back to state statutes on what elements of a controlled substance prescription a pharmacist could change. And at the time, Michigan statute was silent. We had no law that told us what elements could be changed on a Schedule II substance prescription following clarification with the doctor. We could change elements on 3s through 5, but we, at that time, could not change elements on a Schedule II. Since then, the law has been clarified and modified to include all schedules, 2s through 5s. So if you receive a prescription that is missing one of these elements, or you need to clarify as a pharmacist, you are allowed to call and verify with the doctor the patient's address, the dosage form, the drug strength, the drug quantity. Say they, wrote it, it's there in numeric, but it's not in alpha. You can call and clarify on that. The directions for use and the issue date of the prescription. And what I mean by the issue date is, say it's January of 2014 and you get a prescription that's given to you and it says January 1, 2013, and obviously the doctor forgot that the year changed, and so you're going to call and verify that, yep, did you mean you wrote this in 2014 or was it written in 2013? Upon clarification, you can change that issue date. A pharmacist is never allowed to change on a Schedule II prescription or 3, 4, or 5 the patient name, the drug itself, or the doctor. And you're also not allowed to change the do not dispense until date. So while you can alter the issue date upon clarification, if the doctor writes the multiple prescriptions for the Schedule IIs, and say they write today, August 27th, and then they've got another one that says do not fill until September 27th, and another one do not fill until October 27th, you cannot change those do not fill until dates. So if the patient walks in and says, I ran out of my Percocet, I've got this other prescription, can you fill it, today, and, the date is prior to the do not fill date, you are not allowed to change that date upon clarification with the doctor. So you can change the issue date, the original issue date, but you are never allowed to change the do not dispense until date. And hopefully that's very clear. And again, if I need to clarify later in the Q&A, I'll be more than happy to address that issue as well. We often get a lot of questions about hospital residents and controlled substance prescriptions, and I think we're getting much more questions in the office now with regards to this, especially since the Part D plans have been charged with ascertaining and assuring that DEA numbers are valid. So I want to clarify to you what prescriptions a hospital resident can write for controlled substances. And basically, they are allowed to write prescriptions for controlled substances, but they must be prescribing those drugs for patients that are obviously, in the scope of the hospital visit. They cannot be working using a hospital's DEA number if I'm moonlighting in some clinic 60 miles away, or even a mile away. I can't use the hospital's DEA number if I'm doing that. So a resident is a valid prescriber. They're a physician. They are allowed to write controlled substance prescriptions. They can utilize the hospital's DEA number, but they must include that 3-digit suffix that designates who the resident is internally within the hospital. And in some cases, they'll have either an R code for a resident or an I code for an intern. You may see that in some instances. You may not necessarily see it, but some health systems are very good about putting that based upon how they register their residents internally. Where you may find some trouble now filling prescriptions using this hospital DEA number with the check digit is some pharmacy software is not adequately communicating that 3-digit check digit over with the claim. So you may have to work with your software vendor to communicate that check digit over to the insurance plan, because if you're not communicating it, you're going to get a reject from the plan because they're going to view the hospital DEA number as not valid. And so you want to make sure you're communicating that check digit. And if your software does communicate that check digit, you may need to work with the health plan or the PBM that may not necessarily have that resident's DEA number listed. So be aware that that may be a concern. You may start, after July 1, there were some internal processing restrictions placed upon plans to ensure that controlled substance prescriptions for Medicare beneficiaries were written by valid prescribers. And so in some instances, the plans and their PBMs shut down all hospital DEAs regardless of whether that check digit was there. So if you start seeing residents' prescriptions coming back as not valid, be aware that there could be two issues. It might be a software issue on your side, or it may be a plan or PBM thing. So just to clarify, a hospital resident can write for valid controlled substance prescriptions using that hospital DEA if the prescription for the patient is in the course of the hospital-related business for that patient. Hopefully that's clear. Now I want to spend a little bit of time and talk about some regulations that impact pharmacy, because again, pharmacists are under obligation to understand not only the laws and statutes, but the regulations that impact prescription and prescribing as well. And one of the key areas relates to the National Provider Identification, or the NPI numbers. NPI numbers obviously are assigned for each prescriber, so a mid-level practitioner will have their own NPI number, just like an MD or DO will have their own NPI number. And CMS regulations require that every prescription is submitted using the correct NPI number for the prescriber. So you receive in your pharmacy a prescription today written by Karen Jonas, who's the nurse practitioner. And the prescription at the bottom has the NPI number for the DO. And you use that DO's NPI number to submit a claim, that's not valid. You must use the NPI number for who actually the prescriber itself was or who saw the patient. So be very clear in your fields, in your software, that you're submitting for the prescriber that's writing the prescription, not who gave them the delegated authority. So for an NP or PA, you're using their NPI number and not the delegating DO or MD's NPI number. And again, they must use their own individual NPI number. They can't use a facility NPI number. So say I work for Sparrow Health System or Blodgett or one of the other institutions. I cannot use a facility NPI number. It must be an individual prescriber's NPI number. And these regulations are because CMS requires that for Medicaid and Medicare, they are not authorized to pay for any claims for prescribers that are excluded from participation in federally mandated funded programs. So that's why an individual NPI submission is very important, because the plans are all screening NPI numbers to make sure that they're valid prescribers. So be aware that you need to ensure you're using the correct NPI number when you're billing prescriptions, whether it's for a drug or a device or a DME product. In addition, an area that creates a lot of confusion is the origin code on the prescription. And I apologize if this slide is not necessarily very clear, but I want to make sure that you're aware that these are the NCPDP recommended origin codes for how you would submit. So if you get into your pharmacy a written prescription, you would submit the origin code of 1. If it's a telephone, it's 2, electronic, it's 3, and so on. Now, if you receive an electronic prescription, say you receive in your pharmacy electronic prescription for a controlled substance, it's electronically signed by the doctor, but your software is not DEA certified for e-prescribing of controlled substances, and or the physician's software is not e-prescribed for controlled substances. So you've got to pick up the phone and verbally verify that the doctor authorizes this prescription. So obviously you have to authorize that element. You can document that piece on how should you submit that as an origin code. Based upon NCPDP classifications, they're saying use the origin code for how you first received the prescription. So you received that prescription electronically, even though you had to make some verbal alterations to the prescription, it still came to your pharmacy electronic, so you would use an origin code of 03. Now, technically, plans are not supposed to be auditing under this dynamic. We are aware of some plans that are, so it's creating a lot of angst amongst the pharmacies. If you're running across a plan that's auditing based upon origin code, your suggestion to them should be, let you reverse the claim and rebill it under the correct code. Or if they don't give you options, let me know and I'd be happy to work with the plans. We've been addressing this issue with CMS and they agree that this should not be an auditable field. It's supposed to be for data recording purposes only. But just so you're aware, this might be a very handy slide to print out, put next to your computer screens, maybe use it as an educational tool and an in-service for your staff to help educate everybody about what is the correct origin code they should be submitting for all prescription claims. Just a friendly reminder to you that everybody that's doing any business with Medicare Part D, whether you're a downstream entity, and that includes all staff within the pharmacy, or whether you're a courier system, you must go through annual fraud, waste, and abuse training. It must occur upon hire, and it must occur annually, and your training records must be kept and documented, because any Part D plan, as well as any state regulator or any federal regulator, has the authority to come into your pharmacy and ask you for a copy of those records. So please remember, you must go through annual fraud, waste, and abuse training. And if you don't have a current version, CMS has a very nice 90-minute version they've got available. That's a great tool for everybody. If you don't know what that is, I'd be happy to provide that to you. If you just want to follow up to me later with an email, I'd be certainly happy to send that link out to you. Another area you need to make sure you're well aware of is the Medicare and Your Rights notice. Previously, this notice only needed to be posted by the pharmacy counter or made available like in the long-term care facility, at the nursing station, or on the med cart. Please be aware that there's been a significant change as of January 1, 2012. At any time a Part D drug is rejected at the point of sale for a Part D beneficiary, you must provide them with a copy of the Medicare and Your Rights notice, and there is a specific version that you must be providing. You see the notice number here, the 10147, and it's got to be distributed in the approved 12-point font. You can't shrink the size and cut it up into smaller versions and stick it in the prescription bag. You must make sure you're handing it to the patient. Just sticking in the bag without verbally communicating that your Medicare and Your Rights notice is there is not going to cut it, particularly since CMS has charged all the healthcare plans in 2013 with verifying compliance. So the plans are being audited by CMS to make sure that they're complying with this requirement, and so they're making sure pharmacies are complying. They will be communicating with patients, asking patients if they received a copy of this notice. They may be sending secret shoppers into the pharmacy with prescriptions that they know will reject to make sure that your staff is providing a copy to the patient or the caregiver. So they will be looking to ensure that your pharmacy is properly distributing this notice. So be very clear that this is a requirement, and under Part D regulations, If you do not comply with any of the regulations under Part D, the plans have the ability to go back and recoup all dollars under Part D. So take this notice very, very serious and make sure that your staff is not just sticking it in a bag and giving it to the patient, that you're handing it to the patient and letting them know that, I'm sorry, their prescription drug was denied by the Part D plan. Here are their rights with regards to how they go about contesting that and seeking a redetermination of coverage benefits. So be well aware that there is an active process in place by both CMS as the plans to ensure that your pharmacy is delivering this notice. If you don't have a copy of the notice, here's where you can find it. Okay, let's talk a little bit about the provider exclusion list. I mentioned earlier that CMS needs to ensure that prescriptions are paid for by valid prescribers, so they're checking the NPI numbers to make sure that a prescriber is not excluded from participation. You, as pharmacists and all pharmacy, must make sure that every individual that's employed by your pharmacy is not excluded, or entities that you're doing business with is not excluded. So you need to be checking these provider exclusion lists monthly. This is a change. It used to be at least annually. Now it's monthly because they are making monthly updates to the provider exclusion list. And you need to be documenting somewhere that you're checking that all your staff are valid individuals and nobody's on the provider exclusion list. So be very aware that plans are also checking. They may be sending attestations to the pharmacy saying, tell me, validate for me that you're checking the exclusion list. So be very aware that they may be asking that requirement of you. And if you don't have the lists bookmarked, here's the web links to each and every one of them. If you didn't download the slides in advance, I can get these links to you so that you can bookmark that. And please make sure you're keeping documentation that you are checking these lists. I will tell you, about a year and a half ago, a very large chain in the state of Michigan was fined a significant amount of money because they had several pharmacists that were employed that were listed on the provider exclusion list, and it was a very hefty fine. So be very diligent in your duties to check these provider exclusion lists. I want to spend just a little bit of time talking about HIPAA privacy and security. Just a reminder that you must have HIPAA security training. That should be done at least annually, but you need to be aware that there are new HIPAA rules that become effective on September 23rd of this year, and that there are requirements by September 22nd of the next year that you will have new business associate agreements in place. So basically, pharmacies will need to make sure at a minimum that you update your HIPAA privacy notices, that you update and expand your business associate agreements, and that you update your policy and procedure manuals. And a lot of the new requirements talk about what your pharmacy will do with regards to notifying a patient or a downstream entity or another organization of a breach of protected health information. So these new business associate agreements and the new HIPAA privacy notices must contain that information on how you will go about notifying individuals of a breach. And if you are not aware how to currently report a breach of protected health information, you are obligated to notify the individuals and entities that did have information that was breached. You are also required to notify the Department of Health and Human Services. That is an online reporting, and that can be done here. And in some circumstances, you must report the breach to the media. And so be well aware of those requirements. If you do not understand those, I urge you to go to the Office of Controller or the HHS for HIPAA and look at the information. Make sure your policy and procedure manual is updated with how you report a breach, and that every individual within your pharmacy understands how to report a breach, because again, any health regulatory entity or agency or individual working on behalf of those organizations can come in and ask any one of your employees how you report a breach. And if they don't know the answer to that, that could be a significant problem for your pharmacy. There's also a really nice privacy guide that's available for you. I've provided the PDF here. Again, if you didn't download the slide, I can get that to you later. It's very nice, and it'll kind of give you some of your obligations that you need to do to assist employees as well as other individuals for protecting PHI information. Lastly, before I close and open it up to questions and answers, I just want to let you know that there are 3 Board of Pharmacy Administrative Rule sets that are open. There was a recent public hearing, so there will be changes coming to the Board of Pharmacy Administrative Rules, both in the general rules section and the controlled substance rules, as well as the animal sedation euthanasia. It doesn't impact too many individuals other than the vets. But be aware that there will be some practice rules that will be changing, and keep posted to MPA for updates. We'll be sharing that with you as they become final. So with that, I know it was a lot of information, and I went very quickly, but I wanted to give time for question and answers. So at this point, I'd like to open it back up to Elizabeth so that she can let us know about any questions that have been submitted. And just a reminder, if you have questions, please feel free to submit them in your question box.
Okay, thanks, Karen. Actually, we had quite a few questions come in this evening, which is fantastic. So let's start with the first few that we got. First question is, can we accept C2 prescriptions from out of state besides Illinois, Ohio, and Wisconsin?
Yes, you are allowed to accept Schedule II prescriptions from any dentist, DO, and MD from any state within the United States, plus obviously the Washington D.C. area. But again, it's just MD, DO, and dentist, not mid-level practitioners.
Okay. Is there a list of certified software that has been verified by the DEA that pharmacies can look into using for their business?
Great question, and we actually recently became aware of a list, and I've been accumulating the list of the software, so we will make sure we get that information out to each and every participant. Obviously, it's updated as more and more providers become out there, but it is a pretty good list to start with of ones that have been certified, so great question, and we'll get that to you.
Okay. Can anyone at a physician's office call in a prescription if given authority by the physician?
Another great question. Yes, anybody in a physician's office that's been given authority. Technically, the physician is supposed to record that, obviously, to assure that somebody's not going to be diverting controlled substances in specific, but obviously there are some non-controlled drugs that are abused. But typically a physician is supposed to have in his office somewhere whether Susie, John, Jimmy are allowed to phone in prescriptions. And if you suspect that there might be individuals within an office that may not have the authority to phone something in, as a pharmacist, you certainly have the authority to call that office and say, is there certain people in your office that are only authorized to phone in prescriptions? And particularly, I would recommend that if you have questionable controlled substance prescriptions that seem to be phoned in for odd quantities for a lot of patients for the same amount from a doctor, we keep urging the offices to utilize MAPs more appropriately, because it really helps the offices know if the individuals that are employed by them are phoning correct prescriptions in, but sometimes the physicians are too trusting and some of their office staff. So, yep, it should be documented. They can give authority to anybody in their office, including the janitor if they want to, but it should be documented in writing.
Okay. How do we know a fax is computer generated?
Okay, I think the question more, I'll clarify because this question comes up a lot. Typically the question is more generated as, how does a pharmacy know that the fax is coming over from a computer to their fax, or how do they know it's coming from a fax, from a physician's fax to a pharmacy fax? And it's a great question because in some instances, some of the electronic health software that's used for e-prescribing clearly will show by a trailer up on top that it's coming from a fax machine. So if at the top it shows a fax number listed, generally that's coming fax to fax, and so therefore it should be considered like a written prescription, and then obviously it need to be manually signed or a wet signature. If however, you're not sure, a lot of times it's just getting to know the physician's office. Say it's a big office and you don't really know, hey, Karen Jonas is sending over a lot of prescriptions. I'm not really sure this is coming to my pharmacy fax. I don't really know if this is a fax or if this is a computer to fax. So call the office, try to get that information. It may help to you. And obviously, if you're not sure, call and verify, document that, and then you'll be safe for however the prescription was signed that you've documented, you've verified it's a prescription. So it's a very good question because it raises a lot of problems for the pharmacies. They're not really sure how they get that, and if you're not sure, you really need to find out the origin so you know whether a manual signature is required. Great question.
Wonderful. Do they have to be recertified by DEA for software after a given time frame?
You know, the DEA has not made it clear whether they're going to require additional certification. So at present, once they've gone through that certification process, they're good to go. Now, there are additional requirements for internal processing by both the pharmacy and the physician that assure that your system is working adequately. So if you say your pharmacy's been certified and you've gone through and you've been verified by a DEA certification vendor, but you notice that your security features, because you're supposed to do internal auditing, aren't coming up clean, then at that point you would want to go back through a certification process or try to work with your vendor to figure out what's going on. Because once you've gone through the certification, that doesn't mean your job is done. The DEA has specific requirements about internal audits that need to be done to ensure your system is working properly.
Thank you. In regards to signature, what if an electronic prescription is printed out at the doctor's office and then office staff faxes that electronic signature via their fax to the pharmacy fax, so it's not sent directly by their computer?
Great question. Anytime the physician's office staff does anything manual, so for example, they manually print it out an electronically generated prescription, or they manually fax something, manual means manual signature is needed on the prescription. So that's the easiest way for you as a pharmacist or as a pharmacy technician to know what signature is required. If they've done anything manually, that signature from the prescriber must be manually generated. So if they've printed it out in the office and somebody manually faxed it, such as described here, it's got to be manually signed. It cannot be electronically signed.
Great. Can notation of the delegating prescriber for a PA, NP, or CNM be handwritten?
It could be handwritten on a prescription as long as it contains not only the name of the delegatee, for example, say I'm the MD, and Elizabeth, who is also on the call here, she's the NP. If it's handwritten on the prescription, it just can't say Jonas. It's got to say, you know, my complete name, because obviously there could be more than one Jonas. Plus, it's got to say what my credentials are. It's got to say Karen Jonas, MD, or Karen Jonas, DO. So it could be handwritten on that prescription, yes. It's just got to appear somewhere.
Great. Do delegating prescribers' names need to be on phoned-in prescriptions also?
Yes.
Okay.
Same thing. Remember, a nurse practitioner, a certified nurse midwife, and a physician's assistant are not independent practitioners. So even on a phone-in prescription coming into the pharmacy, it's no different than one that's written or electronically communicated. They receive their authority to prescribe under delegation. Therefore, you must have the name and the credentials of who the delegatee on that prescription is.
Does the DEA number of the delegating prescriber need to be included on a telephone prescription?
The answer is yes, same type of thing, because a valid prescription requirement requires the DEA, and again, a physician's assistant and a nurse practitioner, certified nurse wife is not an independent practitioner. Therefore, it's got to be on the telephone order as well as a prescription that's written or electronically communicated. So the answer is yes.
Regarding nurse practitioners, where can we find regulation that defines that a nurse practitioner cannot write for C2 without limits to quantity or location?
Okay. Those statutes are included actually within the Board of Medicine and the Board of Osteopathy rule set. It's one of those strange places where, as pharmacists we think, well, we only got to pay attention to the Board of Pharmacy rules. That's not necessarily true. We need to be aware of the rules for boards of medicine, osteopathy, as well as optometry, if they can prescribe. So I'll be happy to provide those links in the Q&A that we'll pass out to everybody.
Great. What does location of prescribing mean?
Okay, the location code means, or the origin code, I guess, let me clarify. I'm going to answer this question based upon what I think they mean, and if whoever submitted the question, I didn't answer it appropriately, please resubmit the question. So what I'm thinking you mean is that the location of where the physician's office or where the location of the nurse practitioner is with regards to the Schedule II prescription, and that means whether the patient resided within the hospital being discharged, whether they are being discharged from a surgical center or whether they're being discharged from a hospice program. That's what I mean by restrictions from location or quantity for Schedule II nurse practitioners. If that's not what the submitter meant by the question, again, please clarify after.
Great. Let's see, it's just after 7:30 right now. Let's answer just a couple more, and then I'll give out all of the post-test and evaluation information for our attendees to complete.
And Elizabeth, before you jump into the next question, just let everybody know that if they have questions even after this, I mean, my contact information here is at the bottom. They can certainly submit that, and we'll tabulate them in as well, but, or to Elizabeth, but if they could do that, that'd be great.
Absolutely. And then all the questions that were submitted this evening are recorded. So
okay.
We will put them into a document and get those answered as well so we can send them out.
Okay.
Okay, so our next question is, can Michigan licensed PAs receive delegation from a doctor licensed in a different state other than Michigan?
Okay, currently right now, as the way the statutes are written in Michigan, they could receive delegation from an out-of-state, and that does happen particularly on the border areas. I mean, if anybody doesn't know, I grew up in Ironwood, which is on the border of the UP, so, it's obviously we saw, individuals from Wisconsin that they could provide delegation to a PA, an MD from out of state to a PA that's licensed within the state. Where it gets dicey is the other way around. If the PA happens to be from Wisconsin and the MD is from Michigan, it's not necessarily a problem for non-controlled. Where it gets sticky is for controlled substance prescriptions because, again, Michigan law recognizes PAs, NPs, and certified nurse midwives licensed in the state of Michigan to prescribe those controlled substances. So you've got to be very careful for the individuals that happen to be across those borders and whether they're licensed in the state. And a great tool to utilize is the Verify a License site, the link on the Michigan website, the Michigan Gov, and they would have to necessarily be licensed in both states to allow that. And so that'll make it easier. That can be a great tool to help you answer that question, particularly when it comes to a controlled substance prescription. And if you don't get the answer there, you call the office, and if you're really concerned, you know, and your system kicks it out for a controlled substance because the DEA is not valid, that, you know, that may answer your question, and you have to get the prescription from a mid-level. But again, it's possible. Be careful on the controlled substances. Verify where they're licensed to practice in. It's more of a concern for the mid-level practitioner that's not licensed in Michigan.
Okay, let's do 2 more questions here. Can an emergency room nurse practitioner prescribe Schedule II controlled, it's CS, upon discharge from the emergency room?
The answer is yes, the nurse practitioner can for a 7-day supply from the emergency room. And I clarified nurse practitioner because sometimes the nurses, just a regular nurse, not a nurse practitioner, in the emergency room, because they can phone into the pharmacy for a patient that's admitted for a Schedule II, I need more Percocet for my patient on floor 2, they sometimes think they can do it for discharge orders. But the answer is for a nurse practitioner in an ER in a hospital, yes, they can write Schedule IIs for a discharged patient for only a 7-day supply, but not a regular nurse.
Great. And our last question, what about a nurse practitioner writing a C2 for a hospice house patient for a 14-day supply?
Okay, again, understand that they want to take care of their patient. The question can be crossed not only beyond hospice, but for patients in a long-term care facility. We understand that it's difficult for, you know, the nurse practitioners to get back in these facilities, and obviously the patients have a need, but they again are only authorized for a 7-day supply. There are some additional statutes that cover patients under hospice under certain situations as well as long-term care, but they are for MDs and DOs. A nurse practitioner still has that restriction for 7 days, and if they can't get back before the 7 days, then your best answer to them is to have the MD or DO write the order because they still have the 7-day issue.